Neuro Red Flags, level of consciousness, and neuro checks. 1. A sudden change in level of consciousness means you first assess airway, breathing, and circulation, then notify the provider immediately. 2. A Glasgow Coma Scale drop by 2 or more points requires reassessment, airway support, and notifying the provider or rapid response. 3. New confusion or disorientation in a patient who was previously oriented means perform a full neuro assessment, check vital signs, check blood sugar, and notify the provider. 4. If the patient is unarousable to voice or pain, call a rapid response or code, support the airway, and prepare for intubation. 5. Unexplained restlessness or irritability requires checking oxygenation, assessing for pain, monitoring closely, and notifying the provider. 6. Decorticate or decerebrate posturing indicates severe brain injury. Assess the airway, monitor closely, and notify the provider immediately. 7. Loss of protective reflexes such as gag, swallow, or cough increases aspiration risk. Keep the patient NPO, have suction at the bedside, and notify the provider. 8. A Glasgow Coma Scale less than 8 means intubate. Prepare to maintain the airway and mechanical ventilation. Pupils and vision 9. Unequal pupils with sudden onset is a neurologic emergency. Notify the provider and prepare for a CT scan. 10. A dilated, non-reactive pupil may indicate herniation. Call rapid response, elevate the head of the bed, and notify the provider. 11. Sudden vision loss in one eye may indicate stroke or retinal artery occlusion. Activate the stroke protocol immediately. 12. Double vision with acute neurologic changes requires fall precautions and provider notification. 13. New blurred vision with headache may indicate a hypertensive crisis. Check blood pressure and notify the provider. 14. Sudden vision loss may also represent an ocular stroke. Activate stroke protocol and notify the provider urgently. Motor function and strength. 15. Sudden unilateral weakness of an arm or leg means activate stroke protocol, note the time of onset, and call the provider. 16. Facial droop and slurred speech require a fast assessment and immediate activation of the stroke team. 17. Hemiplegia after head trauma requires stabilization of the cervical spine, calling the provider and preparing for imaging. 18. A new inability to lift an arm or grip a hand should be documented, assessed for other deficits, and reported. 19. Seizure-like twitching in one extremity requires ensuring safety, noting onset and duration, and notifying the provider. Headache red flags 20. The worst headache of a patient's life suggests subarachnoid hemorrhage. Keep the patient NPO, call the provider, and prepare for a CT scan. 21. Headache with fever and nuchal rigidity suggests meningitis. Place the patient on droplet precautions, notify the provider, and prepare for lumbar puncture. 22. Headache that worsens with coughing or sneezing suggests increased intracranial pressure. Elevate the head of the bed, avoid straining, and notify the provider. 23. Morning headache with vomiting may be increased intracranial pressure. Elevate the head of the bed and notify the provider. 24. A new headache in a patient over 50 with temporal tenderness requires ruling out temporal arteritis. Notify the provider and expect ESR and biopsy. 25. Temporal arteritis with headache and vision changes in an older adult is an urgent finding. Notify the provider and expect corticosteroids. 26. Brain tumor warning signs include morning headache, vomiting, and papilledema. Notify the provider and prepare for imaging. Seizures and epilepsy. 27. A generalized tonic-clonic seizure requires turning the patient to the side, protecting the airway, patting the bed, never restraining, timing the seizure, and giving oxygen as ordered. 28. A seizure lasting more than 5 minutes is status epilepticus. Call rapid response, give IV benzodiazepines, and maintain the airway. 29. Multiple seizures without returning to baseline is an emergency. Support the airway and notify the provider. 30. If a patient reports an aura before a seizure, ensure safety, call for help, and lower them to the floor if possible. 31. A postictal state lasting longer than 30 minutes without arousal requires airway, glucose, neurochecks, and notifying the provider. 32. Continuous seizures without recovery is status epilepticus. Protect the airway, give IV benzodiazepines, and call rapid response. 33. Seizure medications should never be stopped abruptly. Always taper under provider guidance. 34. Always document seizure onset, duration, and type of movement. 35. An infant with seizure and fever may have meningitis. Initiate droplet precautions and notify the provider immediately. 36. Seizures in pregnancy indicate eclampsia. Maintain the airway, give magnesium sulfate, and prepare for delivery. 37. Phenytoin toxicity presents with nystagmus, ataxia, and confusion. Check drug levels, hold the dose, and notify the provider. 38. Valproic acid toxicity can cause liver failure and low platelets. Monitor liver function and platelet count. 39. Carbamazepine toxicity can cause low sodium and a granulocytosis. Check sodium levels and complete blood count. Intracranial pressure. 40. Cushing's triad includes high blood pressure, bradycardia, and irregular breathing. Elevate the head of the bed, call rapid response, and prepare for ICP management. 41. Projectile vomiting without nausea suggests increased ICP. Assess neurologic status and notify the provider. 42. New seizures in a head trauma patient require immediate notification and seizure precautions. 43. Papilledema on exam suggests chronic ICP. Notify the provider. 44. Headache relieved by vomiting can also be a sign of ICP. Notify the provider. 45. Late signs of increased ICP include Cushing's triad. Maintain airway, elevate the head, and call rapid response. 46. For ICP management, avoid hip flexion, straining, and coughing. Use stool softeners and keep the head of the bed at 30 degrees. 47. Mannitol therapy requires monitoring urine output and electrolytes to assess for dehydration. 48. Hyperventilation lowers ICP but should only be used short-term. Monitor ABGs. 49. A cerebrospinal fluid leak may be confirmed with a halo sign on gauze. Notify the provider immediately. 50. Never insert a nasogastric tube in a patient with a basilar skull fracture. Stroke and TIA 51. Sudden unilateral weakness or numbness means activate the stroke protocol, note the time of onset, and call the provider. 52. Trouble speaking or understanding requires calling rapid response and preparing the patient for a CT scan. 53. Loss of coordination or balance means place the patient on fall precautions and activate the stroke team. 54. Severe visual disturbance may indicate a stroke or transient ischemic attack. Call the provider immediately. 55. A patient on warfarin who develops sudden neurologic changes requires checking the INR and notifying the provider right away. 56. If a patient worsens after receiving TPA, think intracranial hemorrhage. Stop the infusion, notify the provider, and prepare for a CT scan. 57. Hemorrhagic stroke means no anticoagulation. Hold medications and notify the provider. 58. For ischemic stroke beyond 4.5 hours or with contraindications, TPA is not given. Confirm the last known well time and notify the provider. 59. In ischemic stroke, do not aggressively lower blood pressure if it is above 185/110 before TPA. 60. Always screen swallowing after a stroke. Keep the patient NPO until cleared by swallow evaluation. 61. A transient ischemic attack with sudden weakness, slurred speech, or vision loss is an urgent warning sign for stroke. Notify the provider immediately. Meningitis and encephalitis. 62. A positive Brudzinski or Koenig sign indicates meningitis. Place the patient on droplet precautions and notify the provider. 63. Fever, photophobia, and a stiff neck also suggest meningitis. Place on droplet precautions and prepare for lumbar puncture. 64. A petechial rash with neurologic changes suggests meningococcal meningitis. Isolate immediately and notify the provider. 65. Seizures with fever and stiff neck are an emergency. Maintain safety, isolate, and notify the provider. 66. Cerebrospinal fluid leaking from the nose or ears after trauma should never be packed. Test for glucose and notify the provider immediately. 67. Nuchal rigidity with fever and photophobia also points to meningitis. Place in droplet isolation, obtain cultures before antibiotics, and reduce stimulation. 68. Lumbar puncture is contraindicated with increased intracranial pressure. Always assess for papilledema first. 69. Viral encephalitis with altered level of consciousness puts the airway at risk. Monitor closely and prepare for intubation. 70. Bacterial meningitis is a medical emergency. Start IV antibiotics as soon as possible and maintain droplet precautions. 71. Meningococcal meningitis presenting with a petechial or purpuric rash requires immediate droplet precautions and provider notification. Spine and neurotrauma. 72. New paralysis after spinal injury requires immobilization, calling the provider, and preparing for imaging. 73. Loss of anal sphincter tone after trauma indicates spinal shock. Notify the provider immediately. 74. New bowel or bladder incontinence with back pain suggests cauda equina syndrome. Notify the provider immediately and prepare for surgery. 75. Sudden severe back pain with neurologic deficits suggests spinal cord compression. Notify the provider. 76. Loss of sensation below the level of injury requires a full neuro exam, spinal immobilization, and provider notification. 77. Basilar skull fracture is indicated by battle sign, raccoon eyes, and possible cerebrospinal fluid leak. Elevate the head of the bed, place loose sterile gauze, do not pack, and notify the provider. 78. An epidural hematoma often presents with loss of consciousness, a lucid interval, then rapid deterioration. This is a neurosurgical emergency. 79. Spinal cord injury can cause neurogenic shock with hypotension and bradycardia. Maintain the airway and give fluids and vasopressors as ordered. 80. Autonomic dysreflexia in a spinal cord injury above T6 causes severe hypertension, bradycardia, and diaphoresis. Sit the patient upright, remove the trigger, and notify the provider. 81. Any sudden neurologic decline after head trauma requires an emergency CT scan. 82. A halo fixation device carries a risk for pin site infection. Clean per protocol and monitor closely. 83. High cervical spinal cord injury can impair the diaphragm and require ventilatory support. Guillain-Barré, multiple sclerosis, and neuromuscular disorders. 84. Guillain-Barré syndrome causes ascending paralysis and may compromise breathing. Monitor ABGs and prepare for intubation. 85. Always monitor vital capacity and ABGs in Guillain-Barré patients. 86. Severe Guillain-Barré may require plasmapheresis or IV immunoglobulin. 87. Guillain-Barré can also cause autonomic dysfunction with bradycardia and arrhythmias. Monitor telemetry. 88. Sudden inability to cough or swallow in Guillain-Barré is a red flag. Prepare for intubation. 89. Myasthenia gravis crisis causes severe weakness and respiratory failure. Monitor airway, give IV anticholinesterase, and prepare for intubation. 90. Multiple sclerosis can present with sudden vision loss or unsafe swallowing. Maintain safety and notify neurology. 91. Patients with multiple sclerosis are sensitive to heat and fatigue easily. Keep the environment cool and schedule rest periods. 92. Interferon beta therapy for multiple sclerosis often causes flu-like symptoms. Premedicate or give at night to lessen the effects. 93. Multiple sclerosis spasticity can be treated with baclofen. Monitor for sedation. 94. Optic neuritis in multiple sclerosis presents with sudden vision loss. Notify the provider and expect corticosteroids. 95. Amyotrophic lateral sclerosis causes dysarthria and dysphagia. Monitor aspiration risk and prepare for ventilatory or gastrostomy support. 96. Parkinson's disease progression can cause difficulty swallowing and aspiration risk. Involves speech therapy and adjust diet. Neurodrugs and treatments. 97. A rash on phenytoin may indicate Stevens-Johnson syndrome. Stop the drug and notify the provider. 98. Phenytoin toxicity presents with nystagmus, ataxia, and confusion. 99. Chronic phenytoin therapy can cause gum overgrowth and bone loss. Encourage dental hygiene and monitoring. 100. Valproic acid can cause liver toxicity and low platelets. Monitor labs regularly. 101. Carbamazepine toxicity can cause hyponatremia and a granulocytosis. Monitor sodium and complete blood count. 102. Carbamazepine therapy may also lead to bone marrow suppression. 103. Levodopa therapy can cause involuntary movements called dyskinesias. 104. Levodopa and carbidopa may also cause hallucinations and low blood pressure. 105. TPA is contraindicated in patients with active bleeding, recent surgery, or uncontrolled hypertension. 106. Avoid opioids during neurologic checks unless specifically ordered because they can mask symptoms. 107. Mannitol crystallizes if left standing. Always use a filter needle and filter tubing. 108. Steroid therapy increases the risk for infection and raises blood sugar. 109. Benzodiazepines can cause respiratory depression and dependence. Use the lowest effective dose. 110. Lithium toxicity can mimic neurologic changes. Check levels and notify the provider. 111. Anticonvulsants often affect sodium levels. Monitor electrolytes. Pediatric Neurology 112. Ventriculoperitoneal shunt malfunction in a child may present with irritability, bulging fontanelle, and a high-pitched cry. 113. A high-pitched shrill cry in a child may indicate increased intracranial pressure. 114. Hydrocephalus in an infant may show as a rapidly enlarging head circumference. 115. Children with spina bifida are at risk for latex allergy. Use latex-free supplies. 116. After VP shunt placement, headache, vomiting, or drowsiness may indicate malfunction. Notify neurosurgery immediately. 117. Pediatric head trauma with vomiting requires a CT scan before discharge. 118. Febrile seizures lasting more than 5 minutes require immediate intervention with antipyretics and possibly benzodiazepines. 119. Cerebral palsy may present with stiff arms and legs and missed developmental milestones. 120. Progression of cerebral palsy may include new seizures or loss of mobility. 121. Shaken baby syndrome presents with retinal hemorrhage and bulging fontanelle. Always report suspected abuse. 122. Ray's syndrome presents with vomiting and confusion after a viral illness when aspirin was given. Notify the provider immediately. Neuro assessment and post-op safety 123. After carotid endarterectomy, sudden speech difficulty or unilateral weakness may mean stroke. Notify the provider immediately. 124. After craniotomy, clear drainage from the incision, ear, or nose may indicate a cerebrospinal fluid leak. Test the fluid and notify the provider. 125. After spinal surgery, sudden loss of motor or sensory function below the level of surgery requires immediate provider notification. 126. Neuroleptic malignant syndrome presents with muscle rigidity, fever, and altered level of consciousness. Stop the medication and give supportive care. 127. Delirium tremens presents with severe agitation, hallucinations, high blood pressure, and fast heart rate. Give benzodiazepines and monitor vital signs. 128. After craniotomy, new drainage, seizures, or neurologic changes require immediate neurosurgical consultation. Miscellaneous neurology 129. Hypertensive crisis with headache and blurred vision is an emergency. Call the provider and give antihypertensives as ordered. 130. Unexplained syncope with neurologic changes requires vital signs, glucose, ECG, and provider notification. 131. Complaints of the room spinning with fall risk indicate vertigo. Place the patient on fall precautions. 132. Sudden ataxia after chemotherapy or radiation requires assessment and provider notification. 133. Delirium with acute onset and fluctuating level of consciousness requires identifying the cause, ensuring safety, and notifying the provider. 134. Bell's palsy presents with unilateral facial paralysis. Protect the affected eye and reassure the patient of recovery. 135. Distinguish Bell's palsy from stroke. Bell's palsy affects the face only, not the extremities. 136. Trigeminal neuralgia causes severe facial pain with chewing or swallowing. Modify diet and notify the provider if worsening. 137. Cluster headache presents with severe unilateral periorbital pain and tearing. Give oxygen and ordered medications. 138. In dementia, sudden delirium on top of chronic decline requires assessment for infection or medication effects. 139. Delirium itself is acute and fluctuating in nature. Ensure safety and treat the underlying cause. 140. If a patient does not return to baseline after a seizure, call rapid response or the provider. 141. Spinal shock presents with flaccid paralysis and reflex loss below the level of injury. Monitor vital signs, bladder, and bowel function. 142. Diabetic neuropathy may lead to unnoticed foot injuries or ulcers. Daily foot checks are essential. 143. Wernicke's encephalopathy presents with confusion, ataxia, and eye movement problems. Always give thiamine before glucose. 144. Hypoglycemia may present with confusion, irritability, or seizures. Give fast carbohydrates if awake or glucagon if unresponsive. 145. Restless leg syndrome may be secondary to iron deficiency. Check ferritin and treat accordingly. 146. After lumbar puncture, severe headache that improves when lying flat is treated with hydration, rest, and notifying the provider. 147. After spinal anesthesia, severe headache that improves when lying down is also treated with hydration, rest, and notifying anesthesia. 148. After concussion, worsening headache, confusion, or vomiting is a red flag. Notify the provider and assess for bleed. 149. In Huntington's disease progression, aspiration risk from chorea and swallow issues requires diet modification, elevating the head of the bed, and provider notification. 150. A spinal cord tumor presenting with new bowel or bladder loss requires immediate provider notification for possible cord compression. 151. Brain death is confirmed when brainstem reflexes such as pupils, corneal, and gag are absent. Follow protocol and support the family.